All right, I think we are ready to begin. Again, just want to ensure that everyone can hear me. For those that are just joined us, can you please type yes into the chat box? You'll find that on the left-hand side of your screen. Excellent. It appears that you can all hear me, so wonderful. Thank you for attending Asthma Canada's webinar series. Our 2019 webinar series has been made possible through educational grants from AstraZeneca and GSK. This is our second webinar in our 2019 series, and today we'll be speaking about rescue inhaler overuse. I know many of you have been looking forward to this, and it's of growing importance to Asthma Canada and our community, so thank you for joining. My name is Jenna Reynolds. I'm the Director of Programs and Services at Asthma Canada, and I will be moderating today. Before we begin, I'd like to go over some quick housekeeping rules. Please note the webinar is being recorded and will be uploaded to our website. All attendees are muted, but at any point, if you have any questions, comments, or issues, please type into the chat box. I'll be monitoring that throughout. There's also a little blue question mark at the top of your screen. You can also type in any of your questions there. There will be a Q&A at the end, so please make sure to type any questions, though, as we move throughout the presentation, and we'll address them at the end of the presentation. Very quickly, I'd like to highlight some of our work. Asthma Canada is the only national organization solely dedicated to helping all Canadians affected by asthma. We're committed to improving the lives of the Canadian asthma community online through education and support services, research, and advocacy. Our work centers on the missing gaps within the healthcare system, mainly through providing education and support for patients and their families, both in print and online. We also advocate to the Canadian government on improving health outcomes for people living with asthma. Our current focus is on national pharmacare, or access to medications, for fair, equitable, and universal coverage across the country. And of course, Asthma Canada supports research into better health outcomes and the eventual cure for asthma. We have a national research program which supports graduate-level students studying early or late onset asthma. You can learn more at asthma.ca. And much of the work we do is through our community of volunteers and members across the country. These are people living with asthma, their families, parents, caregivers, healthcare professionals, educators, and others who are strongly committed to improving asthma care and quality of life. The Asthma Canada Member Alliance, ACMA, is a free membership of Canadians who engage in all the work we do and who provide support and input into all of our initiatives. If you haven't already, I would strongly recommend you join us. And now I'd like to introduce our distinguished presenter, Dr. Alan Kaplan. Dr. Kaplan is a practicing family physician in the York region of Ontario. He is chair of the Family Physicians Airway Group of Canada and past chair of the respiratory section of the College of Family Physicians of Canada. Dr. Kaplan is also a member of the Asthma Canada Scientific and Medical Advisory Committee. Dr. Kaplan, it's a pleasure to have you with us, and thank you. And now I'm happy to present the presentation over to you.
Thank you very much, Jenna, and thank you to all of you who've signed in today and joined us for this presentation. I'm going to be talking about, I think, is a pretty important concept. It's the concept of how asthma is managed pharmacologically, especially how we deal with the reliever. And as you all know, because you work with asthma or have asthma, there's an awful lot of reliance on STABs, or short-acting beta agonists. I'm going to talk about that issue, why it's a problem both physiologically, pathologically, and behaviorally. And we'll start off with something that I think the healthcare practitioners in the group, I know there's a great variety of different people online, from patients to practitioners, but this is probably a pretty common prescription that gets written. Ventolin 2 puffs 4 times a day as required, 1 inhaler, 3 repeats. And I know this is common. I see it all the time. I get repeat requests from pharmacists and so on about it. But I want to actually share with you that this prescription, though familiar, actually has the potential to do harm. I'm going to come back and discuss that a little bit more. Here's my conflict slide, and I work for just about everyone that makes any kind of inhaled medication. I also have on a couple of government committees as well. So I like to think I'm so conflicted, I'm no longer conflicted. As Jenna said, this program is being sponsored by GSK and AstraZeneca, apparently. So the objective really is talking about SABA over-reliance. Is it really a thing? Is it something we should be talking about? Is it a problem? Why does it happen? And of course, then also, what can we do about it? Well, here are some tattoos that were given to me by a Spanish physician who presented at a recent meeting I was at, and they just blew me away. These are the concepts. These are what people live with in terms of their asthma. You know, and how do I live without you in the top right corner with their blue inhaler? You know, and just how their blue inhaler is so important in their lives that they actually put tattoos of it on their body. This to me was just mind blowing. And then take it even a step further. If they don't want to decorate their body, they decorate their clothing with little holders to hold their blue puffer, because their blue puffer should never be somewhere without them. So this is just how much this is part of the people's life, how important it is to the life of an asthmatic. Well, with that in mind, this is something called the Lancet Commission. The Lancet Commission was an article written a year or so now ago by leading respiratory specialists around the world, including some Canadians, that talked about, we know an awful lot about asthma now, and many, many years ago, when I started practicing, we didn't have anti-inflammatories. Yes, Anik, you should be able to see the slides. Jenna, maybe you can respond back to her, make sure that works. So the way back long ago when there was no anti-inflammatories, we just had bronchodilators. Now that we understand that asthma is an inflammatory airways, it's not surprising that some people did poorly with asthma and even passed away. However, in this inflammation era, where we understand asthma is an inflammatory condition, we have still not eradicated the problem of asthma morbidity and mortality. So why is that? What do we need to do to make this go away? How do we fix this problem? And I guess we'll go back to the first issue, which of course is asthma control. And as you know, the Asthma Society did this survey in 2016. Man, that time has flown by. But it really showed that if you ask specific questions to asthmatics about what's going on in their life, my goodness, the number is like 90% where people say yes to something is affecting their life about their asthma on a regular basis, whether it's a flare-up, difficulty exercising, how often they use their rescue inhaler, how often they wake up at night or miss school or life opportunities. Often patients feel that they're controlled despite these things are happening. And I'd like to say to you that what we'd like for every asthmatic, for every patient with asthma and everybody with asthma to have is have complete control and never have to worry about their asthma, never have symptoms, or never have their life affected by it. But we're not there yet, despite our good medications. As a matter of fact, how do we define control? We define control partly by our use of our blue inhaler. These are the GINA guidelines 2017. They've recently been changed. I'll show you that at the end. But they showed that we want to use our inhaler no more than twice a week. So twice a week would be okay. As you know, the Canadian guidelines say no more than 3 times a week, so it's even a little more permissive. But is that okay to have to be symptomatic and have to require a medication that often? I think it's not really what anybody with any condition would really want to have. And then I go to something which is truly scary, and I don't mean to alarm patients who are on the phone, but the reality is that asthma is a potentially lethal disease. And in this National Review of Asthma Deaths that was done in the UK, they looked at almost 200 deaths that occurred across a year in the UK. And they looked at these patients, and they found that, lo and behold, these patients were not all patients with very, very severe asthma who should have been on biologics, and therefore bad things happened to them. They were often very mild asthmatics, but they weren't taking their ICS. And you can see less than 40% were using even 4 ICS in a year where they should be using 12. And 40% were using more than 1 puffer of SABA every single month, more than 12 in a year. And a staggering amount, 4%, had been given 5 SABA inhalers in a year. We're going to do a little bit of math and talk about actually how many puffs that is in a day, in a week, in a month, in a year. But recognize that the problem here is not so much the disease severity, but the fact that patients don't use their controller medication because it doesn't make them feel better immediately. They do use their blue puffer, which makes them feel better right away. And of course, it's the puffer that every single asthmatic has been first introduced to. Well, what is asthma? And many of you are familiar with a slide or something like this, which shows a normal airway on the left, where there's no inflammation in the submucosa. If you look on the right, you can see that there's a lot of pink and blue, purple staining cells. Those are called eosinophils. That the smooth muscle has got thickened, that the goblet cells get thicker and there's more mucus secreted. And over time, there's some damage to the parenchyma. So asthma is a condition of airway inflammation, not a condition alone of bronchospasm, which is secondary to the inflammation. That being said, how do patients get treated? They get treated with SABAs. And I want to show you a couple of slides wherein physiologically there are problems with what happens with SABAs. So this is a slide that shows the comparison of using SABAs regularly versus using ICS. And you can see on the bottom, on the top line, if you use the ICS in the red, your PD20, your dose of methacholine, goes higher, which means you need a higher dose of an irritant to provoke bronchospasm. Whereas the line on the bottom are people that are using SABA regularly, and you can see that the methacholine gets worse where they get more irritable in their lungs. What this means to us is that regular use of bronchodilators actually causes more bronchial hyperreactivity. Well, in laboratory, and this goes back to 1997, you can see what happens here to someone who is given an allergen. Now, on the top line there on the left is just given a diluent, so nothing happens with the FEV1. But on the line that goes down, a patient is given an allergen that causes an acute phase reaction. That acute phase reaction is well known in asthma, and most people will get better from that acute phase on their own. But then it often goes on to what we call the late phase reaction. So you're seeing that first drop, which then goes up, and then the second drop that occurs. Well, in fact, what happened is if you use the albuterol to treat that acute phase reaction, the late phase reaction is actually worse than if you use placebo to treat the acute phase. So it's completely against what we'd think, where you want to actually manage that symptom, which I understand we'd still want to do, but in laboratory, what actually happens is your late phase reaction is worse. And on the right, you can see that inflammatory markers like sputum eosinophils, sputum eosinophil cationic protein, and EG2 positive cells all go up in the group with albuterol, which is Ventolin in the United States name for it, treatment. So this tells me again that regular use of albuterol actually promotes inflammation. This is a study that came out of the ATS last year, where they looked at mouse airways. That's what the little thing on top is, mouse airways. I hope I made some of these file. What they did with these mice is they challenged them with ova-alba, which is an allergen for mice. And then they either treated them regularly with beta-agonist salbutamol, or they gave them nothing, 7 days, and then they sacrificed the mice. So in a situation where salbutamol was benign, you wouldn't expect to see any difference. But in fact, the salbutamol-treated mice actually had much more significant inflammation. They had more smooth muscle hypertrophy, more goblet cell metaplasia, more inflammatory cells, more eosinophils, more macrophages, and more inflammation overall. So it appears that repeated bronchodilation by salbutamol actually increases the inflammatory changes, and the theory is it's mechanical stress caused by repeated bronchodilation may cause this airway remodeling that occurs. Again, regular use of beta-agonists is bad physiologically. But what about clinically? This is some data that just shows that if you increase your use of SABA, you double your risk of hospitalizations. Kind of a scary thing. So if you use more than 3 SABA per year, you double your risk of ending up in the hospital, both for children and adults. 3 SABAs a year is not a particularly large amount, and this has been shown in the United States with this trial. It's been shown in the UK a number of different times. And in fact, if you're using 1.65 puffs per day, which obviously is hard to do in an individual, but overall you can see that increased risk of exacerbation. So regular use of SABAs has bad outcomes. And some of you are old enough to remember the significant deaths that occurred in New Zealand many years ago, in 1983. This is when I actually graduated. And it was a big thing happening there. They had big deaths of asthma in New Zealand. And Dr. Ian Grant went there from the UK to try to understand why this happened. And he spent quite a time there, and he actually looked at this and he said, well, first of all, patients are not using enough anti-inflammatory. At the time, we had sodium chromoglycate or Intol, which was a non-cortisone anti-inflammatory, which is still available, but nobody uses it very often. And we had inhaled steroids, but these were not being used. But they were using an awful lot of bronchodilators, whether it was theophylline or SABA, and in fact, high-dose SABA by nebulizers. And even more than that, the SABA they tended to use in New Zealand back then was something called phenobarbital or Baratech. And this study from the Lancet shows that if you used phenobarbital versus salbutamol, in itself, just by itself, because it's a stronger beta agonist, the risk of death was 1.5 times higher just because you're using a stronger beta agonist. Message, beta agonist is not only not good for asthma, it may be bad for asthma. Some work from Canada done by Spitzer et al. Was published in New England Journal of Medicine in 1992. For those of you that are healthcare professionals, look at what New England Journal of Medicine looked like back then compared to now. But if you look at the results of this, and they compared the use of amount of phenobarbital, or in fact albuterol, which is salbutamol that we use here in the red box, you can see that as you increase your use of albuterol puffers per year, your risk of hospitalization and death went up significantly. The number that comes out of this is that for every canister per year used of salbutamol, your risk of death doubles. That's a scary number. Now, at this time in 1992, there was not a lot of inhaled steroids used, but I would suggest that patients that tend to use a lot of SABAs now still may not be taking their ICS, and therefore they're still at risk of having bad outcomes because of beta agonist overuse. Here's another study looking from Helen Riddell that looked at patients who were used regular SABA alone, had bad outcomes, whether it's hospitalizations, urgent care visits, visits to the family doctor that were unscheduled, and so on. And of course, the more poorly controlled your asthma, the more beta agonists used, and therefore the poorer the outcomes. So again, the message, using a beta agonist alone is going to not have good outcomes. And that makes sense, really, because we know that SABAs are not anti-inflammatory. Anti-inflammatories are anti-inflammatory. And if you look on the left, this is measuring FeNO. And if you take a steroid-naive asthmatic and you give them beta agonists, in fact, the FeNO tends to go up. FeNO is a non-invasive marker of inflammation. It's a breath test that measures eosinophilic inflammation, or a surrogate of that. So you can see that using beta agonist alone, actually the FeNO goes up in this trial. This is 2017 recent work. But if you compare those same patients who are given ICS, you can see that the FeNO drops significantly post-bronchodilator when treated with ICS. So inflammation is treated by inhaled corticosteroids. It is not treated by beta agonists. So of course, the results are going to be different. But not only is it just that it doesn't treat inflammation, beta agonists, it also, as I showed you, physiologically can worsen the inflammation. Now with all that, here's the data that's occurred. And this is old work done by Sami Suissa. He's a Canadian epidemiologist from Montreal, and he's done this work, this is again years ago in 2000, and he recognized that as you increase the risk of SABA on the left, your risk of mortality, and I apologize for talking about mortality, and I know there's patients online, but this is a hard reality, that patients unfortunately still die of a condition that nobody should ever die of anymore. We have way too many really excellent drugs all the way to biologics. Nobody should be dying. But as I explained to you before, people who die tend to die not because they have severe disease, but because they're undertreating their illness. And you can see if you just use SABAs alone, your risk of death continues to increase exponentially. But conversely, on the right, as you use inhaled steroids, your risk of death falls to pretty well zero if you use your ICS regularly. That's the message. However, with that being said, what's the reality in terms of the use of ICS? This work from Klaus Rabe is European data, but it's exactly the same data in North America. That patients who have asthma use their beta agonists readily, you can see 80% of the time, use their ICS 30, 25% of the time. Now that may be perfectly appropriate in the far right, patients with mild intermittent disease using just intermittent use of ICS, that may be okay for them. But you take the group on the far left that have severe persistent asthma, and they are only using their inhaled steroid 1/3 of the time. Well, I think we understand then why the outcomes may not be so good. Now, what about exacerbations? Now, we would hope that exacerbations don't occur in patients with mild disease, or if they're better controlled. Well, this work, again from Daniel Duzer and more recently David Price, looked at patients who were considered in different severities of disease. And of course, if you have more severe disease, it's defined by the fact you have more exacerbations. But don't be fooled. If you are a quote, mild asthmatic, you still have a risk of needing oral steroids 25% of the time. 1 out of 4 patients with mild asthma will have an exacerbation needing oral corticosteroids. That's a big deal. That's a change of life event. You've been sick enough to require oral steroids, which that's something we want to avoid. Is oral corticosteroids a problem? And again, I recognize I'm talking to patients here as well. I think you have to understand a little bit about oral corticosteroids. Exacerbations, first of all, are a pretty big deal. And as you know, that if you had an exacerbation of asthma, you're missing days off work or education, you may have had to go to the hospital. It's really affecting your quality of life. And you can have these things happen even if patients are fairly well controlled. But I want to talk about oral steroids a little bit. First of all, oral corticosteroids are necessary. If you're an asthmatic and you have an exacerbation and you cannot breathe, you need to have the inflammation treated from the inside out, because taking it from a puffer outside will take too long to work. You need oral corticosteroids. That being said, oral corticosteroids should be a marker for things not being right. And how I treat this personally as a physician is a patient needs oral steroids. My question is not that you should or shouldn't have it. It's why you should need oral corticosteroids. This is some data from an American study that looked at 300,000 patients. 12% of the patients who were using oral corticosteroids were because of asthma. And it's scary. It's not huge doses, 20 milligrams a day. Some of them used a little bit more, 40 milligrams a day and a quarter. And 70% of the patients only received one course of oral corticosteroids. Okay, so, well, in the 30 days after the treatment with corticosteroids, the risk of sepsis or significant infection went up 5 times. The risk of a blood clot went up 3 times. The risk of a fracture went up almost 2 times. Oral corticosteroids are necessary and useful, but they are not benign. And they should be an opportunity to reestablish the why. Why was this needed? What can we do to prevent the next time? How do we prevent exacerbations? Which is going to be an important part of my conversation. Here are some of the other side effects of oral corticosteroids we have to worry about. I've talked about infections. I've talked about bone and fractures. GI side effects such as peptic ulcers, cardiovascular illnesses, metabolic issues like diabetes and affecting the sugar, psychiatric issues. Some people get depressed and even psychotic on steroids. Steroids can cause glaucoma and cataracts, and a whole list, a myriad of other symptoms that can occur. I want to again say that if you need a course of oral steroids because you can't breathe, then you need it. That's not the time to not take it. The time to not take it is to prevent the need of it in the first place. So we're going to talk about how to do that. Then the issue, of course, is, well, okay, with all this that we talked about, ICS is necessary, and if you use ICS, you prevent the need of oral corticosteroids. If you use inhaled steroids, that actually prevents the need of oral corticosteroids very well. But still, despite all this, beta agonists are overused. Why? And I look at this qualitative trial of young adults. And my apologies to anyone who's a young adult on the phone, but as a rule, young adults are the most difficult population to treat because they don't always listen to what they're told. But I actually think what they said here in this study was actually very reasonable. They asked the question, why do you choose your blue one and not use your other one? The answers were very clear and very cogent. I want something that's going to work quickly and is cheap. That isn't the important thing. The important thing is overall the attitude towards their illness. I don't want to have a chronic illness. I'm already pissed off that it's affected my life, my sports, my social issues, my career. I'm afraid of this affecting my life. Out of nowhere, I'll have my life affected, the things I have to cancel. And I'm angry. I'm angry having an illness. So instead of accepting the stigma of having chronic illness, I'm going to be in denial. And if I don't take a regular medicine, that means I don't have a disease. By the way, I can't live without my blue one because that's the one that works, but I can live without the purple one, red one, brown one, orange one, because that one doesn't seem to do the same thing for me. So this is the thought process that goes behind a patient when they decide, they make a decision that says, I'm going to use my blue one and not use the other one, because they may well be in a bit of denial about their illness, and I certainly can understand that. It's probably hard to be sexy to someone looking for a spouse if you're puffing on something because you can't breathe. And then if you ask questions about what do you want from your medication, what's patients' focuses on their immediate relief treatment? And this is work done by Martin Partridge, who's a UK respirologist. And he said, well, patients, he asked the questions, he said, well, they want something that gives them immediate relief. They want to feel confident, and they do feel confident, that they can make their own decisions in their asthma management. Think about that for a second. They want to be in control of their own illness. They want to do things on their own, and I come back to that a little bit later. They want to use medication when they need it. They don't want to take medication all the time. They want to use it when they need it. They want to take control of the illness by themselves and manage on their own. They do not want to be beholden to physicians or educators. They consider us a necessary evil. And there's a couple of other topics here, which I'm going to come back to a little later in the talk, but I'll mention it here because it's on the slide. There are other options now for reliever therapies, such as ICS combination therapy. They like those medications better because you have the two things together. And they prefer to minimize their medication options altogether. Understand the patient beliefs. Well, with that in mind, this kind of slide is not surprising. What do patients do when they suffer an asthma symptom worsening? Well, you can see on the left, which is the short-acting beta agonists, they readily increase that to treat their symptoms until they get a very high amount of SABAs and they get into trouble. And that's the picture of an exacerbation. I need more and more SABAs and I can't breathe and I have to go get help. What they should be doing, and what many of you who are patients know you're supposed to be doing, you're supposed to be increasing your inhaled steroids when you start worsening. And that is quite clear. Those are called action plans. And many of you have been given an action plan, and you're told increase your ICS. Yet, what is patient behavior? Okay? and if this is not you, I apologize, but this is in this study what they did is that patients continued on their same dose for a number of days because, again, they wanted to see, well, do I really need this? Is it that important? I'll probably be okay. Let's see what happens. And then when they do increase it, they don't double, triple, quadruple it as they're supposed to. They take one extra puff. Therefore, not a big surprise that action plans don't work. And a recent trial was shown that an action plan quadrupling for inhaled steroids for adults were minimally effective, and quintupling for pediatrics didn't work. And I think the reason why it didn't work very well is because by the time the patients increase their dose, they're already in the midst of their exacerbation. We have to get in there earlier and prevent the inflammation from building in the first place. So this behavioral thought process about SABAs and the use of SABAs is pretty big. And I'll come back to the thought, for those of you that have asthma in the audience, I'm sure there's many of you, what's the first drug you were given for your asthma? Well, the first drug I've given to every single asthmatic until recently was a beta agonist. And that's the one that patients associate with their asthma. And I'm reminded, I tell the story of a young lady who I've got permission to tell her story because we spent a day together in the emergency room one day when she came in with status asthmaticus. And she fortunately didn't have to be intubated, but I certainly had everything ready to do so. And when she could talk, she told me this is what her life was. Her life was she slept with her beta agonist on her pillow. And she'd wake up 3, 4, 5 times a night, take a few puffs of her SABA, and then go back to sleep. She was given another puffer, quite appropriately by her doctor at the time, but she didn't take it because she didn't think it was important. Well, you can imagine it's pretty important. Okay? How do you deal with someone who's overusing a beta agonist to the point actually where she could have died? Well, we'll talk about how to do that and what I did with her. So this is the old GINA guidelines. And you can see that step 1 of the GINA guidelines was as needed short-acting beta agonist PRN. So our guidelines propagated the concept that the first drug we give is a beta agonist. Now, GINA has recognized this and has made some changes now, and I'll show you that at the end. But this is partly not just patient quote fault or behavioral issues. This is actually clinician fault and world leaders part, right? GINA is the Global Initiative for Asthma. That's the global guidelines for asthma. Thank you for the comment. And we have Canadian guidelines, but there's also global asthma guidelines. The Canadian guidelines are being reworked right now as well. GINA has just been released with their update. So what about starting with inhaled steroids versus starting with a beta agonist? And this is a reanalysis of the START study by Helen Riddell from Australia. And very interestingly, she showed that depending, again, on how much beta agonist you use, based on the symptoms you used, you can see that a very significant difference occurs between those patients that were using budesonide on the bottom line versus those that were not using inhaled steroid on the top line. So if you use budesonide, you have less exacerbations, and it seems as the more symptoms you have, therefore the more inflammation you have, the worse things are, and the more you needed that inhaled steroid. So again, even in mild asthma, which this study was, you need to be on inhaled steroids. Which brings up a paper called The Paradoxes of Asthma Management. It was written by 3 world leaders, all of whom I have the pleasure of knowing and have worked with. Christine Jenkins from New Zealand, Eric Bateman from South Africa, and Paula Byrne here from Hamilton, the Firestone Clinic in Canada. And they said, wait a minute. We have this Lancet Commission that says things aren't right. What is it that's wrong? What can we fix? Now, there's 5 paradoxes here. I'm not going to go in order. I'm going to start with number 3. ICS treats underlying inflammation, but patients still perceive SAB as a medication that benefits them. I've talked about that already. Number 5, there's a disconnect between a patient's understanding of asthma control and their symptoms. So I know that a lot of you are quite willing to accept some symptoms of asthma if it means you don't have to take as much medication. Well, I would suggest that might be a mistake because undertreating inflammation is dangerous. Number 4, LABAs are not safe, but SABAs are perfectly safe. Well, some of you are familiar with something called the SMART trial. It's called the salmeterol monotherapy asthma relief trial. It was done many years ago. In inner city United States, they gave patients in inner cities free salmeterol, which was just fine. About 35 or 40% of patients were on ICS to start with. But what do you think people who didn't have any money for drugs in the United States did? They took the free drug and didn't get the other one they have to pay for. So they used salmeterol alone. And unfortunately, 19 young Afro-Americans died of their asthma on salmeterol alone. That led to the black box warning on SABAs. which included a black box warning with LABAs with ICS, which has now been taken off. So you all know that using a LABA alone, long-acting beta agonist alone for asthma, is contraindicated. We don't do that because of that trial. But has anyone ever told you that, in fact, there's an increased risk of death by overusing SABA until you heard it from me here today? So this is one of those things where nobody has ever talked about SABA not being safe, but LABAs has been talked about not being safe. I want to get into the first two, and I want to just show a very basic picture. I've been showing this particular slide for probably 25 years. What happens in asthma? In asthma, you have not the top line, which is the bronchospasm, as you can see, spasm being caused with the smaller blue, which is the airway, but you have airway inflammation. And that swelling in the airway may not be symptomatic until the spasm occurs, and suddenly you go from a reasonable amount of blue, which is airway, to not very much airway at all with the far left there. So what you really want to do is you want to treat that inflammation, because even with a little bit of spasm you see on the right, there's still lots of room there for the air to pass through. So airway inflammation is the problem. Okay, so our steps, talking about confusion of our patients and patient behavior. So in step one of asthma, I've already showed you that the recommendation was SABA alone. Well, let's talk behaviorally for a minute. As a patient, you're told that you can do whatever you feel you want to. You take the SABA if you want to, you don't take the SABA if you don't want to, and you are in complete control, or so you think, of your asthma. But when things get a little bit worse and the SABA is being used a little more regularly, the clinician starts stepping in and says, oh, wait a minute, you've got to take this other medication. You've got to take it regularly, every day, twice a day. It doesn't matter how you feel. It doesn't matter whether you think you need it or not. You must just listen to me, the clinician, and do what I tell you and take this medication regularly. Well, is it any large surprise that patients may not do that, especially if they don't completely understand the necessity and why? Is it doesn't make them feel better acutely. They just have to believe the clinician. And if they do and they understand it, they do better. But as you know, many patients say, well, that one doesn't make me feel better, so I don't take it. So, no surprise, they undertake their ICS and they over-rely on their SABA. Here's some data from Canadian adherence data. And this goes back a few years ago now. It really isn't terribly different now. It doesn't really matter which drug. You can see 4 of the major drugs on the bottom there. The picture's the same for all of them. The prescription gets filled, it gets used, and then it doesn't get repeated. So that we look at a year, less than 1 in 5 patients continues to be on their maintenance therapy. That's the reality. Well, this one scared me even more. This is some work from Jerry Krishnan that looked at, and this is not new, that looked at patients' behavior after coming out of the hospital. You know, it doesn't get much worse than that. I am so short of breath that I can't breathe. I get rushed to the hospital by ambulance because I think I'm going to die. They stick needles in my arms. They put medicines on my mouth. They keep me there until I breathe. And then they say, okay, I can go home. But to go home, you have to take this puffer and you should take this prednisone pill to treat the inflammation. Well, look what happens. Medication is usually given for a couple weeks. At day 7, they just stop their medication. Doesn't matter. They're feeling better. They don't need it anymore. Okay, what about their ICS? Same thing. At day 7, half the patients are using their ICS. They were just in the hospital, not being able to breathe, afraid for their life, but now the memory is short. A week later, they've stopped their medication. That's the problem with adherence and the behavior. But I would like to suggest to you that patients are completely adherent. They're adherent to what makes them feel better. They're adherent to the SABAs because it works for them. Okay? And control to a patient, some patients, means when I have symptoms, I take medications that make me feel better. I have control of my illness. We have to change that conversation and understand why people are doing what they're doing, both clinicians, healthcare workers, and patients. To do that, we created something called the Asthma Slide Rule. This is part of the Asthma Right Care Initiative, which is an international program run by the International Primary Care Respiratory Group, for which Canada is a member. What we did was we counted puffs per inhaler and the frequency in a year. So let's go back to that prescription at the beginning. Remember, Ventolin, 1 to 2 puffs 4 times a day, 1 inhaler, 3 repeats. Okay? There's 200 doses per puffer. So at 4 puffers in the year, 1 inhaler, 3 repeats, that's 800 puffs. Well, it's 365 days a year. 800 divided by 365, that math is too hard. Let's say 400. That's basically 2 puffs every day. To me, that means that prescription, which isn't that big of a deal, 4 puffers of Ventolin a year, means you're symptomatic every single day of the year. I don't think we should be accepting that kind of approach at all. And this thing, this asthma slider rule, is very nice because it shows people how many puffs they're actually using. Because people don't really think about it. They take it when they need it, they put it away, they don't really think about it, and lo and behold, hey, wait a minute, I've used 4 or 6 puffers in this year. Well, that's not so many. Well, actually it is. It means they're using an awful lot of SABA, and I've shown you the data that SABAs are not good for you. So how do we change this? Well, part is how we communicate. And what I'd like to show you is a study done in 2010 by Wilson that looked at shared decision making. And they used 4, we say extra steps. I like to think they're not extra for my practice, but I'm sure there's days when I'm not quite as good as I'd like to be, which means that first you identify the patient's goals and preferences. Okay? It's a conversation. Summarize back to the patient what it is that they want. Because ultimately, it doesn't matter what you want as a healthcare practitioner. It matters what the patient wants. Then you talk about the choices, the options of treatment, and you negotiate treatment regimen. Sometimes that's not going to be any different than what they came in on. Sometimes it's going to be very different. Sometimes it's going to be they're willing to try something. Well, by doing this, though, by going through not a healthcare practitioner down instructions, but actually working with the goals and the preferences of the patient and working together, this study showed a significant improvement in the amount of controllers and a decrease in the amount of SABA being used, and a double the likelihood of having well-controlled asthma. This didn't take any medicine at all. It took a conversation. So as a healthcare practitioner, do this. Patient, Mrs. Smith, what is it you would like about your asthma? What can we do to make this better? Okay, here's some choice of what we can do about it. And as a patient, you need to say to your doctor what it is you'd like about your asthma to be better and how you're willing to work together to make that happen. Well, asthma control is what we talk about. Having good asthma control, not using your beta agonist, not waking up at night, not having life events, certainly does improve outcomes in terms of quality of life, risk of exacerbations, and activity levels overall. It's what we aim for. But despite that, some work done from the Realize trial by David Price showed that even patients who were controlled still have exacerbations. Now, clearly, if you're not controlled, your risk of having exacerbation getting on oral corticosteroids, OCS, is higher. But if you're controlled and you've done everything right, you've taken your medication the way you're supposed to, okay? You wash the cat so the cat runs away. You know, the dog is kept out of the room. You've quit smoking. You've done all the things you're supposed to do. There's still a risk of having exacerbations because things still happen, whether they're infections or exposures or so on. Okay? So one quarter of patients who were controlled still have an asthma attack. So I want to suggest to you that it's not just about the controller. The controller is very important. Do not misunderstand. It's important that you take the controller you need to keep yourself controlled. But I also want to talk about the reliever. How do we actually ensure that we don't just use a SAB as a reliever, which does not treat the ongoing inflammation, but we treat with inhaled steroids? How do we do that in a way that aligns with the patient's desires? Is there a different reliever, and is there an option for this? And here's the concept here. The concept is that if you intervene immediately, you prevent the inflammation, which is sort of the gold color they're building, whereas that inflammation will eventually lead to an exacerbation, oral steroids, etc. But if we intervene at the time the symptoms are occurring by treating the inflammation, then we can prevent this exacerbation from occurring by treating the inflammation at the time it is happening. Now, how do we do that? Well, we could use a drug that was available 30 years ago called Ventide, which is a combination of beclomethasone and Ventolin. It was in the UK. It didn't make it to Canada, and it was taken off the market. People didn't understand it. So we don't have anything that has a combination like that. They do have it in Italy. It's a Chiesi product that's available there. What we do have in Canada is combinations with formoterol. Now, formoterol is not salbutamol, but it works just as fast. In fact, it lasts longer. So we can use formoterol as an acute reliever because it works just as fast as salbutamol does. I want to show you a couple of quick studies. I'm going to go through quickly that talks about the Sigma trials. And these were comparing as needed budesonide formoterol, or Symbicort, for asthma control and prevention of exacerbations in mild asthma patients. They're either mild or uncontrolled on SABAs alone, or they're controlled on low-dose ICS. There's 2 different groups that got into the study, and the results were exactly the same for both groups. So sigma 1, they compared a reliever and a preventer. Okay? The preventer could be either placebo or budesonide 1 puff twice a day. And the preventer could be a SABA or budesonide formoterol as the reliever. Okay? They were checked very carefully. There was regular visits. They had diaries, and they had medication measurements on the actual inhalers as well. So there's a lot of intervention here and a lot of conversation with them. They were mild asthmatic patients. The FEV1 you can see down 1, 2, 3, 4, 5. The fifth line is 84%. That's pretty normal. But you can see at the bottom there that these mild asthmatics, 1 out of 5 of them, had a severe exacerbation in the last year. So once again, mild asthma is a misnomer. Mild asthma still can be very important. So they did a few endpoints. The first was a measurement of controlled, called well-controlled asthma weeks. They also measured lung function. They measured exacerbations. So looking at the blue, which was as-needed terbutaline, versus the red, which is as-needed Symbicort, or budesonide formoterol, you can see that asthma control weeks were better by using a little bit of inhaled steroid in the PRN, budesonide formoterol. But make it perfectly clear here, I lost a slide here, I'm sorry, that by using, there's a bar there, it should come up, and if you would imagine beside the red bar, there was a brown bar, which seems to have disappeared. But what that brown bar was a budesonide twice a day, and it showed much better asthma control than the Symbicort PRN. So message number 1 is regular use of inhaled steroid is still the best management for mild asthma. But let's look at another endpoint in terms of exacerbations. And you can see here that using SABA alone has a significantly higher risk of exacerbations, at 20% over the year. But when you use a little bit of steroid or the regular steroid, it didn't actually matter. The exacerbation rate was the same. So using steroid will decrease exacerbations. Whether you use it regularly or whether you use it at the time the symptoms are building or the inflammation is building, it does the same thing. It prevents exacerbations. What's really exciting about this, I can't advance anymore. Jenna, I can't advance. There we go. All right, here's adherence, and you can see that 80% of the patients were adherent in this study to their controller, which is great, which means that how many patients actually take their budesonide twice a day, every single day as their regular controller. In this study, it was 80%. In real life, it wouldn't be that good, so I think it overperformed. Sigma 2 just looked at Symbicort PRN versus Symbicort plus terbutaline, which is the SABA PRN, directly. The outcome was exacerbations. Mild asthmatics, again, you can see 22% exacerbated in the year. And here you see the difference in exacerbations. There's no difference. No difference in exacerbations between using the inhaled steroid at the time you need it versus inhaled steroid regularly all the time, which is basically the concept here. Okay. Again, adherence in the second trial was not quite as good. It was 63% because there was not as many visits and there was less diaries. Here's what's really exciting about both of these trials. Whether it's Sigma 1 or Sigma 2, you compare the budesonide regularly, which was a little bit better for control, but no difference in exacerbations. And you look at the dose of the steroid, the amount of steroid used versus using the budesonide formoterol as required, and you can see between 70 and 80% of the dose was needed to get the same exacerbation reduction. So think about this. You get the same reduction in asthma exacerbations by using Symbicort PRN as, with one quarter or 20% of the dose of steroid overall. I think a lot of you would like to avoid the total amount of steroid to the body. Well, one question that comes up is, well, doesn't that mean I'm just going to have to use my Symbicort every single day as my rescue? Remember, these were mild asthmatics, and if you look at the data here, that whether we used it at the rescue at all, whether it's used the terbutaline in the brown or the Symbicort in the red, you can see that most days they used zero rescue altogether. Okay, as much as maybe 30% altogether of the days they ended up using a PRN in these studies. So these were mild asthmatics. They didn't need something every single day. Most days they didn't need anything. So the Sigma trials really here are looking at comparing Symbicort PRN to terbutaline or SABA alone, and no question there that was much better. Okay? But it was the same in terms of exacerbation risk as using regular ICS. But again, I'm going to want to be clear, it was not as good as regular ICS for overall asthma control, and there's a little bit of improvement even in the regular steroid in lung function in terms of FEV1 by about 40 mils, which is not very much. So if you can get your patients to take their inhaled steroid regularly, then that is the best treatment. When we talked about patient behavior and outcomes and what people do, they tend to reach for their rescue therapy. They want to be in control, take it when they need it, and therefore, as needed, budesonide formoterol is an option in mild asthma. Interestingly, if you look at the SIGMA trial and the patients that use more rescue versus less, you can see that the lines diverge there between the top one, which is SAB alone, and then on the left one here, where they used only two days where they use more than two rescue, they're pretty well the same. But as you use more rescue inhaler, you can see that there starts to be a change, not just among the SAB on the top, but between the middle line, which is budesonide, and the bottom line, which is the Symbicort. So what's happening is that amount of budesonide doesn't seem to be enough for those patients that are very symptomatic. And as I move on to this one, 6 puffs per day and 8 puffs per day, you can see that the budesonide wasn't enough, and there's still a risk of exacerbations, much lower than the risk of the SABA alone. But if you look at the line of the red line on the bottom, there was actually 0 exacerbations. These people were using 8 puffs a day of Symbicort for the rescue, and they didn't go on to needing prednisone because you're treating the inflammation at the time that it's happening. Whereas the budesonide group, unfortunately, because they weren't able to increase the budesonide, they couldn't prevent that exacerbation from happening. So built into this whole philosophy is the concept that you're treating the inflammation at the time it's happening. Now, not all SABAs are bad. This is a restaurant in Porto, Portugal that a colleague of mine took a picture of and showed me because he knew I was talking about this. So I just wanted to try to make you guys smile. I have no idea if this is a good restaurant, though, so I can't claim that was good. So if you do go to Porto and use this restaurant, you can let me know. All right, how do we solve this? And this is not building at all. That's a shame. So I think the point I wanted to make this, and this came out of the Paradox paper. This is supposed to be a slide that builds, but we lost those builds, but that's okay. The concept here is that we want to have patients being in control of their therapy, that they make decisions on what they need. Now, sometimes that is not enough, and using Symbicort regularly would mean that they require something more. They have to actually work with the clinician to decide on how they're going to step up therapy, and they do have to step up therapy. But since, as a rule, patients don't like being told, which is what this cartoon is supposed to show, we want them to be part of the decision and understand what they're doing and be in control as much as they can be. So what about a more significant disease? And this is the Further Paradoxes, an article written by Richard Beasley from New Zealand as well, that said that ICS fast onset lab as a reliever has greater efficacy and better safety profile than SABA across the more severe asthma as well, steps 3 and 4, yet still in those levels, patients are still getting SABAs as a rescue. Well, that makes no sense at all, right? So again, even back in 2017 and 18, Gina still suggested that you could use, as you see in the bottom right, as-needed SABA or low-dose ICS formoterol as a rescue, but SABAs were still indicated as the rescue for step 3, 4, and 5 for patients with more severe disease using a regular controller. So there's been a meta-analysis done of all the different Symbicort PRN trials in moderate to severe asthma. I want to just show you quickly the results of that. This is comparing all the different trials, and many trials have been done now using Symbicort PRN on top of usually Symbicort versus other treatments that may be Symbicort, maybe Advair, that uses salbutamol or terbutaline as the rescue. And every single one of those trials using roughly the same dose of inhaled steroid had a much better reduction in exacerbations using the SMART strategy, Symbicort maintenance and reliever therapy, versus using a beta agonist. How about if you increase the dose of the ICS? Well, this is patients compared Symbicort SMART versus a high-dose ICS with a SABA. Same sort of picture, that the SMART strategy outperformed even the higher dose of regular ICS. I want to show you one of those trials, which is the Kuna paper. And what they did in this paper is they compared the rescue therapy, the controller of salmeterol fluticasone or Advair 250 to Symbicort 200 2 puffs twice a day, to budesonide 1 puff twice a day, plus Symbicort as a reliever. And what you can see here by the exacerbations is the fixed dose of ICS LAVA had roughly the same dose of exacerbations, p.52, that's the same. But if you compare the anti-inflammatory reliever of Symbicort, there was a significant reduction in exacerbations. So even in more severe disease, using Symbicort as your reliever did better in terms of reduction of exacerbations. Again, that same kind of message in the study looks at the total dose of steroid because there's less oral steroids, less exacerbations, and because they used the dose of Symbicort 1 puff twice a day, and then Symbicort for the rescue, they used less inhaled steroid as well. So same bang for your buck, if not better, with a lower dose of inhaled steroid. Now, I know that I have some people here that work with very significant asthmatics as well, so I added on this little bit of work as well. And this is these are not head-to-head comparisons. These are comparisons of trials, so don't take it for more than it is. But if you just talk about reduction of exacerbations, and the Symbicort data, the SMART data showed you the roughly risk of exacerbations is 0.59. You reduce it by that much. Tiotropium or Spiriva is a fantastic drug to add on to ICS-LABA to reduce exacerbations, but it only reduces it by 0.76. Biologics, which are tremendous drugs, and they change people's lives, and some of you have severe asthma on the line, and you're on these medications, and you know what it's done for you. They decrease exacerbations, but again, the difference here is these are injections. They're $25,000 a year. And if you look at the reduction in exacerbations, the numbers are not all that different than using SMART as a strategy. So it's time for us to reconsider our reliever therapy to prevent exacerbations. And Richard, again, has created this sort of overall adjusted therapy strategy that you start off with your ICS-LABA as a PRN. If you need it regularly, then you move on to it regularly, 1 puff twice a day plus PRN. And if you need more, you take 2 puffs twice a day in PRN, and then from there you step up to other maintenance therapies. You can also step back down, so if things are really well and the season is better and it's not an allergy season, maybe you can reduce it. Now, there are some barriers to anti-inflammatory reliever. There's some concerns this is a very expensive reliever, and certainly is more money than salbutamol. However, is it more money than missing a day of work or a week of work? Is it more money than being in the hospital? Is it worth the money to prevent a course of oral steroids? I'm going to talk about covering up inflammation in a moment with some data. I want to talk a little bit about the behavioral stuff because I know this is a change. This is a paradigm change. Okay? Can I do without my Ventolin? It won't work as well. Why are you doing this to me? And it's really important that we work together as clinicians and patients to understand that we're doing this for you as a patient to make a difference in your life to improve your outcome. And then the other question is, well, does it mean it's going to be way too much steroid use? I want to show you some data on that. This is a cost study. This is a solo trial, one of the Canadian SMART trials we did, comparing SMART to conventional best therapy, CBP, and it showed a significant reduction in asthma educations and total overall cost. So cost-wise, in big picture, SMART's cheaper. An individual patient, if they're only going to buy a salbutamol, then yeah, it's going to cost them less, but what's the cost of things like missing work and exacerbations? In that same solo trial, we also did sputum eosinophil trials. What we did was looked at the sputum eosinophils at the beginning and at the end of the therapy, and we compared conventional best therapy again to Symbicort SMART. So you can see in the conventional best therapy that inflammation measurement, sputum eosinophils, is far and away the best measurement of eosinophilic inflammation in the lungs. Did not change much in the conventional best therapy. Doctors were given whatever therapy they thought was appropriate. Symbicort SMART, though, by treating inflammation at the time it happens, did reduce inflammation. Okay, again, in these other studies, not everybody is using the Symbicort every single day. They're not just using a whole bunch more. I showed you in the mild asthma, 70% of patients use nothing, and in more severe asthma, 60% of patients did not use a regular reliever. Again, I don't want to talk about death, but I have to. This is a young man that made the news. He was a young man who died of asthma. He was found by the ambulance. He called the ambulance, and they found him with a long-acting beta agonist salmeterol in his hand. He had a cardiac arrest. They took him to the second closest hospital. The big noise in the newspapers, and the Toronto Star said the ambulance drivers killed the boy. But in fact, he was asystolic when they got there. He was going to die. Now, he was going to die not because of his severity of his asthma, although I can tell you that he had a really good family doctor. He had a certified respiratory educator who was very knowledgeable and very, very compassionate. He had a really good respirologist as well, all really good people, all of whom had given him the medications that he should be having, but he wasn't using them. So what if he had never had a SABA? What if the only drug he had was an ICS-LABA, was Symbicort? I don't know what would happen to this young man, but I want to think about Symbicort PRN as a novel ICS delivery method. We've been having real trouble getting people to take their inhaled steroid. Well, why don't we let them take it the way they want to? Take it as they need to for their symptoms. And of course, that may not be enough for some people. They may need to be on a regular maintenance as well. But at least let's get started this way and move away from the SABA alone. What did the Lancet Commission say? Again, this group of world-renowned specialists said it's time to replace as required short-acting beta agonists with combination inhaled steroid and fast-acting beta agonists as a reliever therapy. That is what the steps are to make a big difference. Here is the new GINA guidelines. Okay? Step 2, which is patients who are having regular symptoms, or symptoms a few times a week actually is step 2, should be on a regular inhaled steroid. But the alternative is to use as-needed low-dose ICS for formoterol because I showed you the exacerbation risk is the same. But still the first treatment should still be regular ICS if you can get patients to take it. But because they don't have regular symptoms, they probably won't. But the question is, should ICS-LABA be a reliever at every stage and abolish SABA? And GINA said yes to that. And I want to show you step 1, where they got rid of SABA entirely, and they said that it's time to use ICS formoterol as the rescue therapy alone and get rid of SABA. So I know it's hard to change. This is a paradigm change. Right? I think these people will be much happier pushing a round wheel than a square wheel, but they have to have time to think about it and make that difference. So asthma control is a bit elusive, but exacerbations still happen. SABA overuse is a physiologic and practical problem rooted in patients' beliefs. If we're going to take away their safety valve, we need to replace it. We have a way of doing that that's easy, sensible, and practical. So I will tell you that this prescription can do harm and will do harm. It's time for us to make a change. And Tim Harrison wrote this article with Matthew Martin in the European Respiratory Journal and said, is it time to move away from short-acting beta agonists in the management of asthma? And I think the answer is yes. So I'll leave you with this picture. If you're using SABAs alone to treat asthma, you're just fanning the flames of asthma inflammation. Let's make a change. Let's change things for our patients' betterment and for your betterment. Thank you very much for your time. Jenna, I know there's some questions that have come in through there. I didn't catch all of them when they went in, and I know we only have a couple more minutes.
No worries. Thank you, Dr. Copeland. That was very informative, very detailed. I'm just going to quickly go. We're going to run a little bit over, but if people are able to still attend and to listen, that would be great. A question from Melanie. What about using Ventolin before exercise?
That's a fantastic question. Thank you. There's exercise symptoms are broken down into 2 groups. Patients who have poorly controlled asthma, where the inflammation is not managed, and therefore exercise is a trigger of their inflammatory asthma. Then there's the other group that have not probably asthma, but they have something called exercise-induced bronchospasm. This is not an inflammatory condition at all. This happens usually with the symptoms after the exercise. It happens because of osmosis, osmotic changes in the lung, temperature changes, and so on. So for exercise-induced bronchospasm, then beta agonists, leukotriene receptor antagonists, these are all things you use before exercise and they work very nicely. But if you actually have poorly controlled asthma, for which inflammation is the cause, then using an ICS-LABA for prevention will work beautifully. And in fact, the difference is you can tell if someone has asthma symptoms with a cold, then they don't have exercise-induced bronchospasm and they need inhaled steroid. But if they never get symptoms with a cold and they only ever get symptoms with exercise ever, then they may have exercise-induced bronchospasm. And in fact, that's probably the one group where using salbutamol would still be perfectly fine, as well as, by the way, COPD patients, which is a different conversation. Otherwise, I think there's no reason not to use Symbicort as your rescue therapy, as your exercise preventive therapy.
Great. From Sarah, what about the side effects of ICS? If I increase even by 1 dose, I get muscle cramps and I shake so bad I can't function.
Yeah, you're probably getting the muscle cramps because of the beta agonist, I would assume. ICS very rarely causes muscle cramps, but beta agonists do. Interestingly, LABAs in some patients are better tolerated than SABAs for that side effect. We know that people get low potassium when they use a lot of SABAs, and that doesn't happen with LABAs. So this is an issue, and ideally in someone who's having such sensitivity to beta agonists, we want to prevent beta agonists. We can do that by using other bronchodilators like anticholinergics, but first and foremost, you'd want to ensure that you get the asthma under as good control as possible so you don't need to use any rescue therapy at all if you're that sensitive to beta agonists. So it's probably not the ICS that's doing it. The good news, though, especially in mild asthma, but even in the moderate severe asthma, if you use Symbicort as your maintenance instead of SABA, you end up with a lower total amount of ICS and therefore less steroid side effects.
A question from Stacy. How much, just in general, is too much of ICS?
How much is too much of ICS? That's actually a very interesting question, and there is an amount of which ICS no longer gives you any benefit. Unfortunately, that's hard to predict who that is in different people. Some people that sort of level is going to be hit at 500 micrograms a day of fluticasone. Some people it's going to be 1,000, and some people it's going to be 2,000 or more. It's going to depend a little bit on the inflammation that's going on and the triggers that are occurring to them. Unfortunately, we have no easy way to measure that. The best way would be by measuring sputum eosinophils and continuing to increase the dose until the sputums are managed. But as a rule, about 1,000 micrograms a day of fluticasone is probably as much for chronic management as anyone should ever be on a regular basis, as a general rule. We've now started to introduce long-acting beta-agonist combinations of lower dose of ICS, trying to keep those doses down. The other thing to remember about steroids, of course, is we get steroids in other doses as well. We get it nasally for allergic people. We get it topically in creams. So we do want to be careful with the total amount of steroid given because there are risks of use of ICS as well. You're quite right. Okay, high doses of ICS over a long time has been seen in the COPD population, increase the risk of pneumonia, osteoporosis, fractures, cataracts, glaucoma, mood issues, and so on. So I think it's a very reasonable concern about how much ICS you're using. That being said, if we don't use enough ICS, my option then is going to be oral steroids. And if we use oral steroids, we know those side effects are all magnified in terms of risk. So use enough ICS to prevent the oral steroids is really what you want to do. And you may want to add other things to that ICS to make it work better, like a LABA, like maybe a leukotriene receptor antagonist, like a long-acting antimuscarinic like Spiriva, or even moving on to a biologic, because we're recognizing that very high dose ICS for a long time is something we like to prevent. I hope that answered that question.
Great, and we have a couple of more for those that aren't able to attend. Again, this is being recorded, but I think if Dr. Kaplan's able to, we'll continue to stay on a little bit longer for these questions. From Sarah, is it normal for an asthmatic to have a lower oxygen level, 94, 95?
No. It depends a little how old you are. It depends on what else is the matter with you, Sarah, and I won't ask any more personal questions. But if you are a younger person, by young I would say under the age of 50, your oxygen saturation should be normal. And if your oxygen saturation is 94%, you need to answer the question why. It may be if you had asthma for a long time, that you have some degree of fixed airway obstruction from years of untreated inflammation and have a form almost of COPD because of that, which means your oxygen may not be able to come all the way up to 100. But while a normal oxygenation can still be considered 95, I would still say the question is why, is there something you can do about it? So I would say that that's something that is not normal, and maybe you're normal before you get too scared. But to answer your question, no, I wouldn't consider that normal.
Thank you. From Jaya, if a mild asthma patient is on an LTRA, what rescue inhaler is the best?
So that's a good question. Interestingly, in the Sigma trials, they were actually recruiting patients with mild asthma on Singular as well. They haven't done a separate analysis on people on LTRAs alone, although you bring up an interesting question. I think, though, in terms of first principles for me, my rescue therapy should still be the same thing, no matter what the controller therapy is, whether it's Singular, whether it's nothing, whether it's ICS alone, whether it's lab ICS, the rescue therapy should still be Symbicort. For the reasons I've showed you, that it decreases exacerbations and treats the inflammation at the time it's building. So whether it's a leukotriene as their initial controller, which is perfectly fine if that's working well, Symbicort rather than Ventolin should be their reliever.
Question from Jeffrey. I use Symbicort multiple times daily, 2 pops in early morning, 1 to 2 at noon, and 1 to 2 at 4:30. I'm concerned about overuse and talk with my doctors, but they aren't concerned. Is this okay? Are there alternatives?
Well, that's a much more complicated question than you think, because it requires a complete review of your asthma. As a rule, patients should not need that much Symbicort. That doesn't mean it's too much for you. It might be the amount that you need. Some people need to be on more than the sort of classic 1 or 2 puffs twice a day. But if you're needing that much regularly, the question is what else can be done? Is there a trigger that needs to be evaluated? Is there something that has to be looked at in terms of the technique of the drug and the way you're using it? Are there comorbidities that need to be looked at, such as rhinitis or GERD? Or if you have more severe disease, should you be considered for a biologic? So I wouldn't cut it down based on the fact that you think it's too much. I would, in discussion with your doctor, see if you can get by with less. And if you can't, then the question is, why can't you, and what you should be stepped up to improve that. Perhaps something like Spiriva added on to Symbicort 2+ twice a day would prevent you from needing as much Symbicort during the day. But these are just ideas, and without knowing the specifics about your case, I can't answer that. But I would say that that means your condition is a little bit more severe if you need that dose to keep yourself controlled, and you need to have a whole review of the asthma as to why that's happening.
Thank you. If I take my ICS throughout my trigger season, can I stop or take a break for my good season, or do I have to take this all year long no matter what?
These are some really good questions, guys. And so the GINA guidelines suggest that patients should take their ICS regularly. Canadian guidelines say the same thing. We should use our ICS regularly. But I completely get the concept of saying if you know what your trigger is, and you're sure you know what your trigger is, and that trigger is gone half of the year, then why would you need to take the inhaled steroid regularly through the part of the year when you're not being triggered? So I can certainly understand seasonally treating your condition if you're quite sure what your trigger is, and you've never exacerbated in the time of year where your trigger is absent. Those are some buts, right? What I would make sure if you're going to do this is you start your inhaled steroid again pre the season. Don't wait till the season started to start your medication, because ICS take time to work. They have to get into the nucleus of the cells. They take at least 6 weeks for the full effect. So you want to start at least a month before the season. If you're going to do the strategy of cutting out during your good season, make sure you restart about a month before the season starts so that you're well treated when the season kicks in. This should be done in conjunction with a clinician. Please don't just listen to me on this. All right, it's something you have to talk to.
Absolutely. Just so everybody knows, some questions are quite specific, but this is meant to be general information, not any advice. From Sarah, what do you do when a patient is using all their medications properly, ICS, Singulair, and still requires 1 to 2 doses of Ventolin a day for 7+ weeks and has also done 3 courses of oral steroids during that time?
Well, it's sort of similar to my last answer. You have to go back to the basics. Is the adherence as good as we think it is? Is the patient taking the medication regularly when they're feeling better? Are they taking the medication properly? You have to go back into inhaler technique, because there's many ways you can take an inhaler incorrectly. That has to be done properly. You have to look at the triggers that are causing it. Is there a PET? Is there smoke, cigarette smoke, and so on? What occupational triggers there might be. You have to look at comorbidities that might be worsening it, such as rhinitis, nose, and gastroesophageal reflux or acid. And if all that stuff is the case and everything's perfect, then they may well have a concept of severe asthma, and they're going to have to step up therapy. Again, the first thing I would do is switch the reliever from salbutamol to Symbicort, because we just talked about that. But in addition to that, they may have to step up therapy to something in addition, and they may actually be someone who's on all that stuff, who may have severe asthma and may have to be stepped up to a biologic.
Great, and this will be the last question. When should you ask to be referred to see a respirologist or a specialist?
Well, it's a very politically charged question. So I think that if you're doing your part as a patient and you're taking your medication properly and you're not controlled, you need to have a conversation with your doctor saying, I'm not controlled based on these criteria that all the guidelines say, so what are we going to do about it? And give your primary care practitioner an opportunity to work with you to get things fixed, because they may not realize that you're not as controlled as they think you are. So make sure that they understand where the problems are, that you're having symptoms regularly, that you are having to use your reliever more often, that you are dyspneic or you're coughing or whatever the symptoms are, and give them an opportunity to fix that. If you're not getting anywhere with that, you're still having problems, especially if you're getting recurrent exacerbations needing prednisone. I told you how important that is. I think that's perfectly reasonable to say, well, maybe you could question, is it time for me to see a lung specialist because this is really affecting the quality of life, right? I think you might get a better response than just walking in saying, you have to send me to specialist right now. I think a conversation and a working in combination will be there. Remember the study I showed that talked about doing things with the patient's goals and preferences all together. We have to work as a team, both the patient and the clinician, When we do that, things work better. But sometimes I understand that there may be blocks that occur and you get railroaded in there, and I think it's not unreasonable to ask for help at that point. But I would suggest you ask for it rather than demand it. It's going to be for a better relationship with your clinician down the road.
Great. Well, thank you very much, Dr. Kaplan. We definitely appreciate you taking the time. That was very informative. Thank you, everyone, for attending. If you have benefited from our webinar series and would like to see similar programming, please consider making a donation at asthma.ca/donate. And if at any point you have any further questions, please email us at info@asthma.ca, and we'll be happy to help. We also have our free helpline that we can connect you with to speak to a certified respiratory educator. Thank you again, everyone, and have a good day.
Thanks, Jenna. Thanks, everyone.